Developmental screening, surveillance, and assessment in children are often complemented by the use of special screens such as the PEDS test. As these special screens often require additional time and resources, one benefit to PEDS Online is that it enhances reimbursement through private insurance companies as well as Medicaid. To help ensure adequate reimbursement, this video will provide guidance on how healthcare providers can appropriately report standardized developmental screening and testing services. The use of the PEDS test is reported using the CPT code 96110 and is often reported when performed in the context of preventive medicine services. This code may also be reported when screening is performed with other evaluation and management services such as acute illness or follow-up office visits. As the descriptor for CPT code 96110 is specific for developmental screening with a standardized instrument, it is important that healthcare providers understand that this does not include questions about development as part of an informal developmental survey or history. To properly bill and code for PEDS screening, the healthcare provider must first attach the 25 modifier to the Preventive or Evaluation and Management Service Code to denote the office visit is a separate service from the screening. The healthcare provider also has an alternate option of attaching the 59 modifier to code 96110 to show that the screening service was separate and necessary at the same visit. Recently, CPT code 96110 was revised to clarify that the code may be reported more than once during a single date of service. The code descriptor now states, per standardized instrument. Therefore, the frequency of reporting 96110 is dependent on the clinical situation. For example, if the healthcare provider performs multiple standardized screens, such as the PEDS test with PEDS DM, then code 96110 will be reported with 2 units. Modifier 59 may again be required for each additional unit to indicate that the services were distinct. In a patient whose developmental screening is normal, optimal coding indicates that the healthcare provider should link code V79.3 or V20.2 to CPT code 96110. The code descriptor for V79.3 is Screening for Developmental Handicap in Early Childhood, while code V20.2 describes a routine infant or child health check. If health insurance companies do not recognize this coding combination, there are a few acceptable coding alternatives the healthcare provider may utilize in cases of normal screening results. One alternative is to use ICD-9 code V79.9, Screening for Unspecified Mental Disorder and Developmental Handicap. If the healthcare provider documented a reported developmental delay in the child's health record, despite normal results after developmental screening, another alternative is to use ICD-9 code 783.42, Delayed Milestones, 315.8, Other Specified Delays in Development, or 315.9, Unspecified Delay in Development. The drawback to using one of these 3 codes, however, is that they may not be used at the next well child visit, since the child's developmental screening from the previous visit was normal. In cases where developmental screening results are abnormal, it is common practice to use ICD-9 codes that are sufficiently vague so as to not interfere with a more complete diagnosis made by those to whom the patient is referred. Commonly used diagnosis codes in response to abnormal screening results include 783.4, developmental delay, 309.23, academic inhibition or school problems, 309.3, disturbance of conduct, 315.4, developmental coordination disorder, and 784.5, other speech disturbance. If a valid claim is not accepted, the American Academy of Pediatrics is willing to help with denied claims and may be contacted through their coding hotline listed here or at AAP Coding Hotline at aap.org. Here are two clinical vignettes to help synthesize the billing and coding process. At a 24-month well child visit, the mother describes her toddler as wild, completes the PEDS test, and responds positively to the question, "Do you have concerns about your child's language skills?" The nurse scores the PEDS test and places the answer sheet on the front of the chart with a red arrow sticker next to it. When the pediatrician examines the child, he is alerted to ask the mother about her observations of the child's language ability. He then confirms the delay in language and makes a referral to a local speech pathologist. In this case, the well child visit would be coded as CPT code 99392 with modifier 25 and an ICD-9 code of V20.2. The PEDS test would be coded as 96110 with an ICD-9 code of V20.2 and 315.31 for expressive language disorder. Vignette number 2. At a follow-up visit for bilateral otitis media, the pediatrician notes the patient missed her 12-month well child visit. He requests that the child's father complete the PEDS test and PEDS DM. The father endorses no concerns in any developmental domain. The pediatrician reviews the father's completed PEDS test and PEDS DM and asks him if his daughter is using single words to convey her wants and is using words to label common objects. No concerns at all are reported, and this is consistent with what the pediatrician has observed in office visits. He tells the father they will continue to monitor for any evidence the child is not acquiring skills at an expected rate. All this is noted in a few sentences in the chart note. This clinical example would be coded as follows, with modifier 25 appended to the Preventive Medicine Service, code 96110 reported for the PEDS test, and code 96110 appended with modifier 59 for PEDS DM to show the screening services were separate and necessary at the same visit.